an educational consultant for SET India. That's my disclaimer. This is what happens to me when I attend a surgical meeting as a surgeon. All my colleagues, they keep on throttling me that what are you doing in an ID meeting with everyone there. This is my work day in and out. So this is what I perform every day. When I'm at work, I'm on the robotic console, and you must be wondering what a robotic surgeon is doing here in this meeting. It's probably my passion and maybe my distinction in microbiology, which is still attached to me for so many years. But it is not more than that. It's a saga of this particular patient. So this was a case referred to me some time back, where the patient had 3 hernia surgeries done, and you can see the state of affair that there is a big wound over there. And what's more annoying is this foul-smelling discharge. So somewhere what has happened is in the entire cycle of his treatment, things have gone wrong, and maybe the wound was not managed properly in the index problems. Today, as surgeons, we see wounds into 2 categories. One is an acute wound. So we see wounds which are getting infected post-laparotomy. This is one of the cases where you can see that there is a superficial sloughing of the wound. And this is another case where the wound is created. What happens with these wounds is that they get exposed to bacteria. And that's where the role of all of us come together in managing them. Or this young lad, which was present, and he had come with a big injury, something like this. So these are the patients who come with acute wounds. Then we have another category of patients which we see, which are known as hard-to-heal wounds. That means everything else has been tried for these patients, but nothing is working. So a classical example of these are the patients with this kind of ulcers, where they have been debrided and then they keep on in the hospital for a couple of weeks because maybe they have not got the right solution for the treatment. Or a case like this, there is a vascular insufficiency, but the wound is chronic, loaded with bacteria, and what we can do about it, we are not clear. So today, if you see any wound, what happens to the wound is that initially it leads to presence of bacteria. The bacteria in the wound come from either an endogenous source or an exogenous source. Subsequently, what happens to that is you will either have the bacteria staying there as a colonizer, or it may go into full-fledged infection. So there are 2 pathways in which it can go. And from there, once we give a standard of care, 2 things can happen. One is it will heal completely, or it will become a wound which is hard to heal. So this is a normal cycle which all of us know when we are treating our patients. So the biggest bug today is the infection. And once you have a wound which has got infected, everyone starts jumping around. And we have 2 solutions today. One is to bombard them with antibiotics, or keep on painting so many medications on the top with antiseptic agents so that we feel good. I think it's more of a feel-good factor. We keep on applying a lots of solutions on that, right from betadine to everything possible, and we do that. But what is the danger when we are doing that? The danger today with that kind of an approach is resistance. Today we know that there is resistance to the bacteria, we have resistance to the antibiotics, and we have resistance to the antiseptics. The last one particularly is very, very important because it is not well documented in the literature, but even the agents which we are using for our painting and draping, there is also an evolving resistance against this. So as a fraternity, we are facing these 3 problems. And all this combined leads to the biggest problem called AMR, antimicrobial resistance. So this has become a big challenge for all of us today because of the haphazard use in which we are managing our wounds. And we all know that overuse of these antibiotics has led to this. And it is very shocking to know the data that about 10 million deaths will be happening every year. So we are talking about COVID era, we are talking about other era, but this is what's going to happen by 2050 according to the statistics, which is a very scary picture because the number of antibiotics used and the way we are treating our patients is getting very detrimental. And the data is saying that about 30% of antibiotics which are prescribed are unnecessarily. So if you see the literature in terms of inappropriate use of antibiotics, 1 in 3 patients in the US in the outpatient is been getting antibiotics inappropriately. In UK, it is 1 in 5 in the NHS. This is from the published data. But in India, I think it's probably 1 in 1 because we feel good when we write an antibiotic. And this is what is happening. So when I don't give antibiotic to my patients post-operatively after a surgical treatment, then they are looking at me and they're ready to throttle me. Hey, you're not giving an antibiotic. But this is the fact. So we know that this problem leads to longer hospital stay, and longer hospital stay means cost. Today, we're not talking about the cost like the West, but the days will come soon where you're going to talk about it. So is there any solution today where we can do something different in terms of the wound care? Yes, we know that there are antimicrobial stewardship programs nationally and internationally, and we all follow. We know that these things, the hand hygiene and the doctors and the surgeons, the pharmacists, everything. So we give that standard of care bundle to everyone. But apart from that, for locally managing the wound, apart from the standard of care, what is available today. So if you see today, the market is flooded with all sorts of coating. They probably have coated everything possible on this planet on the wound to see that it affects very, very well. But what is a caveat? The problem with that is that they release certain chemicals and they also release certain pharmacological agents. So are we trying to do that to make the wound better, or are we making it worse? That's a big question. So every time I'm going to slap on a dressing which is going to be coated with something which is antimicrobial, I may be even inducing resistance. So what's the new concept? There is a big paradigm shift today. The newer concept is, rather than killing the bacteria, which the standard of care is going to do, can we move to removing the bacteria? That means just remove the bacteria from there. And what it will do, by removing the bacteria, you're reducing the risk of infection, and also your antibiotic usage also will be significantly less. So in essence, we now have a new technology which is looking at reduction of the bioburden. So the whole aim is now shifting towards reduction of the bioburden, and that's where the SORBAC technology comes in. This is a newer concept which works purely on removing and reducing the bioburden. Yes, it is published in the literature, and today it is becoming slowly a standard of care that by using this SORBAC technology, which is coated with this particular molecule called DACC, it helps in that. How does it work? Let's see that. So basically, SORBAC technology works by this principle. It is a dressing which binds onto the surface of the wound. Thereby, it inhibits the proliferation. It's like a sticky note. You're putting in a sticky note onto a wound, you allow the bacteria to cling onto that, and by that, when you're going to take off the dressing, you offload and you remove the burden completely. And there is a significant reduction even in the colony count, which has been proved in the literature. So essentially, it works by hydrophobic interaction. This is how the technology works on. So essentially, it does a physical sequestration. So all the bacteria, they will cling onto that sticky note technology, and what will happen is they will all get retained onto that dressing. And the next time when I'm going to get the dressing off, it's going to help me with that. This is how typically it looks under the microscope. So all those organisms which you are seeing over there, this is how it works on that. So you can probably see there'll be some amount of Staphylococcus aureus infection, the other infection. So all the bacteria will be loading onto that, and this is how it works there. So for example, the same wound which I showed you earlier is loaded with this particular bacteria. The moment I'm going to apply a SORBAC technology dressing, what it will do is, A, it will remove the bacteria. So the bioburden is going down. B, reduction of bacteria, reduction of inflammation, because the bacteria which is going to release a toxin is already been captured by that dressing and it gets off completely. The moment that happens, my antibiotic usage is going to go down. So I will have a significant reduction in my antibiotic usage because of that. And along with the standard of care, I think this holistic approach will help the patient a lot. And the most important, no release of chemical and pharmacological agent. Remember, I talked to you about this in the remaining dressings. This doesn't happen here. That is one of the biggest advantage which I feel is this particular technology is going to make a revolutionary change. So is it effective against crucial pathogens? We all know that WHO has today identified this 5 top-notch bacteria as identified in terms of that these can cause surgical site infections. And the evidence is SORBAC technology works against all of them. This is again published in the literature. So we know that these sticky notes, this particular dressing is also going to help for all these particular bacteria. And there is sufficient evidence that the colony forming units, before and after, there's a significant reduction. In fact, now we are doing an international trial soon where we're going to do it for our own Indian patients. And I'm convinced with this particular technology that it's going to use. More important is also works against biofilm. We all know about biofilm, especially in the orthopedic surgeons, implants, I put in a mesh. Yes, there is a published literature about it, that in vivo there have been observations. So this is an article as early as last year, which talks about use of SORBAC technology even in preventing biofilm. So it works there. So essentially, it is a technology which is used to combat the antimicrobial resistance by bacterial binding, and that's why the resistance factor doesn't occur. So this is going to be a game changer, because since it just works on removing the bacteria, we're not going to look at anything in terms of resistance. In fact, there will be more applications where we're going to use it in a better way. So what are the different ways in which the SORBAC technology today has a platter? So there's a wide range of platter available for all different sorts of wounds available today. So for every specialty, maybe a gynae specialty or a general surgery or an orthopedic, today we have something available. So we have this product called QTMX SORBAC, which reduces the biviral load. Then we have something which is known as a Leukomed SORBAC. So depending on what usage you're going to use it, essentially you can cater to that. There's also something which is known as a debris clean, which is one of the agents where you can remove the superficial debris, which is also available. Then you have something like a Leukomed Leukoplast, which is like a transparent dressing. So even on the day 2 or 3, if I find the wound is weeping, immediately I'll go in there and I'll use this technology and use that. And more so important, I think there was a discussion about the fungal infection yesterday. We even have a SORBAC fungi. A lot of times we see women who are coming for gynecological procedures, hysterectomies, they will have some fungal infection in the crevice if they have a higher BMI. This is something which works very well, because this is again something which will attract and stick the fungus on that. So it's not only effective for bacteria, but it also works effectively good for fungus as well. And then we have Leukoplast, which all of us have used. So this helps in reducing the cross-transmission. So to conclude, ladies and gentlemen, today we know that in the wound management, we have got, this is the flow chart. We've got antibiotics, which we use. We've got biocides, that means disinfectants and antiseptics, but we know that there is a resistance to that as well. We are using anti-infective agents. There's a resistance to that as well. But I think there will be a paradigm shift in terms of the DACC SORBAC technology, which is essentially going to aim of moving from killing the bacteria to removing the bacteria, and that's what it's going to help. So finally, last 2 slides, madam, for people who are on evidence-based medicine. So we all keep on harping, evidence-based medicine. Is it evidence-based medicine? Look at this particular trial. This was published in the British Medical Journal, okay? That parachute jumping, preventing death. One arm, one group with parachute, one without parachute. You guys are ready without parachute to jump from the plane? Yeah, I can see some smiling face there. But look at the conclusion. The conclusion said it did not reduce death. Evidence-based medicine. That means I should start jumping from the flight without a parachute because evidence is saying that. But what we forget when we read a particular paper is the methodology. And the methodology in this particular paper was jumping from this height, from 2 feet. Yeah. So this is where is the catch of evidence-based medicine today. Yeah. So when we talk about evidence-based medicine, yes, it is good, but I think there is something which is known as experience-based medicine. When madam is saying something, I have to accept it. There is also something which is known as environmental-based medicine. If I have a patient from Northeast and the patient is in a village, maybe the standard of care would be different. So finally, to conclude, I get inspired by this gentleman who is wearing the jacket. He's already wearing a jacket with the SORBAC technology. So what he does is he initially starts treating his patients with antibiotics, yeah? And he exceeds in that and he feels everything is good with the antibiotics. But he still finds patients coming back. Then he says, antibiotics are not working, let me use antiseptics. So he uses near-antiseptic dressings, he's putting onto the wound of the patients. He starts working and using that in his patients. He's doing that, but still he gets patients coming back with the problems. Finally, he feels that I think there's a new technology come in, which is the SORBAC technology. And this is where he's now using the SORBAC technology and he finds that it's very good. He's using it in his patient. It works very well. And this is how I think we escalate our treatment protocol. Yeah, we decide what is going to be the best of our patients. Thank you very much for your kind attention. These are my contact points. You can take a picture. I'm available anytime. It's available. That's my email. I have got lots of videos on the YouTube which you can refer to. And thank you for having me here as a surgeon, a robotic surgeon, talking about the antimicrobial technology. Thank you so much.
Thank you, Dr. Jignesh Gandhi.